All right, welcome everybody. We're super excited to have our first annual Mayo Clinic Melanoma Patient Education Symposium. So appreciate all you attending. Um, the format will be the speakers. I'll introduce all the speakers were handpicked. They're all colleagues, friends, melanoma experts, and their talks are slated for 30 minutes. Everyone's talk is going to be shorter than that. So one will be a little ahead of schedule. Two, there's time for Q&A. So if you have questions, we're going to ask people to use the mics, and we can pass around the mics. But there's a lot of people on Zoom, so we want to make sure they can hear the question as well. So feel free to ask your questions. And so some housekeeping stuff. If everyone can silence their cell phones, that'd be appreciated. Restrooms around the corner, Starbucks just across the hall. MRF table, I think most of you saw that already to learn about the amazing organization, as well as get to know some of the contacts, such as Melissa from Cabana Life and her team. That's a skincare focused company that supports melanoma advocacy and research. Presentations will be recorded. They'll be available online, so you don't have to take pictures. You're welcome to, but you'll have that available online. So we'll go ahead and get started. I'm going to introduce Kyleigh. Kyleigh had some travel struggles with the fire at the airport yesterday, but she was able to get in late in Orlando and then drive up from Orlando. So thanks for doing that. Kyleigh is the Melanoma Research Foundation's Chief Executive Officer position, so the CEO for Melanoma Research Foundation. They're an awesome organization that we collaborate with, and they do great things for melanoma. She has held a position since 2017. In her previous role, she was Chief Development Officer. She led the foundation's development program and worked with donors and families to make charitable donations to significantly impact melanoma research, education, and advocacy. So without further ado, Kyleigh, thanks for joining us.
Thank you, everyone. It is so exciting to be here and to host the first annual Patient and Caregiver Symposium with Mayo. Dr. Jacob, thank you for your kind remarks. It's a pleasure to partner with the Mayo Clinic. As you know, Jacksonville is one of the locations. There's also one in Arizona and Minnesota. And we are very fortunate to be able to partner with all of the locations and are just very grateful to be able to interact with you all here today. I just wanted to note one other thing, one other housekeeping thing in your folders that you all received is the agenda, and there's some materials and a survey. And we would love your feedback. This being our first annual, we really want to make sure that we continue to improve and have the information that you all are seeking. So if you wouldn't mind making sure throughout the course of the day that you just fill out that survey, that would be really helpful to us, and we would appreciate that. I would also like to thank our incredible sponsors. Many of them are here in the room today. These are companies that allow us to host these symposiums all over the country at no charge for patients and caregivers. The Melanoma Research Foundation funds the entire event so that we're able to provide this educational opportunity free of charge. So we're very grateful to all of our sponsors. I wanted to highlight a few events that are happening here in Jacksonville. One is the Get Naked Jax event. There's a postcard in all of your folders and a QR code here that will take you to the event. But this will be our 5th annual, and this event was started by a patient here in Jacksonville who really wanted to create awareness about melanoma and encourage people to hashtag get naked. And he is here today. Jason, would you mind just standing up? So Jason is a huge advocate of melanoma prevention and early detection, and this will be our 5th annual event. All of the funds raised go to support melanoma research. And to date, we have funded 4 research grants. In fact, proceeds from this event funded our first ever pediatric melanoma research grant. So really impactful work. And I would encourage all of you, if you live here locally, to either attend the event or get involved if you have extra time and you want to join the planning committee. Jason will be here all day. He's a great resource. Melissa from Cabana Life, who's also here. Melissa, if you want to wave. Melissa is also on the committee, and she can share more. And Bo, also on the committee, can also tell you guys a little bit more about the event. But again, it funds amazing, impactful research, which is helping advance hopefully a cure for this disease, but certainly more options for patients. So you can check that out. I also want to highlight one other area that Mayo just recently became involved with, which I think is just incredible. Mayo, all three sites joined the Melanoma Research Foundation Breakthrough Consortium. This is a program that we started in 2010, where we bring together clinical, high level, the best of the best clinical sites from all over the country to collaborate on groundbreaking research and to also foster collaborations in the field. So Mayo recently joined this, and we're really excited about, again, the potential for elevating research and fostering collaboration in the field. So I just wanted to showcase their involvement there. And I wanted to share the facts. We're here in Melanoma Awareness Month. Skin cancer is the leading cancer here in the United States, melanoma being its deadliest form. And we are here to educate you all. That's why you all came today. But I think it's really important that you now become advocates to your wider community and really share the facts about skin cancer and melanoma, because it's so critical. And it's a cancer that unfortunately many people dismiss. It's just skin cancer, just cut it out. So again, you all here are getting educated and empowered, and we would just encourage you all to pay it forward and share that information back in your own communities. So a little bit about who we are. So the Melanoma Research Foundation was founded in 1996 by a patient who was dealing with her third recurrence of metastatic melanoma. And unfortunately, at that time, there were only 3 FDA-approved treatments to treat melanoma, and there wasn't much happening in the research space. So it was really out of her advocacy and her passion for creating more options for patients that the Melanoma Research Foundation was formed. And thankfully, over the years, research has evolved, and now we have 30 FDA-approved treatments to treat cutaneous melanoma and 2 treatments within that to treat uveal melanoma. And the mission of the foundation evolved because so many people were, again, having access to more treatments. People were surviving the disease, and they needed to be, excuse me, educated about their options. So the mission evolved to what it is today, which is to not only fund research, but educate patients, caregivers, their loved ones, as well as the general public about melanoma, treatment, prevention, early detection, and awareness, as well as advocating for issues that impact the melanoma community, both on the state and federal level. And we are a national foundation. So we are based in Washington, D.C., which you heard about my travel woes. We're based in Washington, D.C., but we are national. So we have events all over the country. And in your packet, you'll see where some of our upcoming events are. So I wanted to touch, just touch a little bit on research, the first pillar of our mission. So to date, we have funded over $26 million in peer-reviewed research, which has led to patents, clinical trials, and most importantly, FDA approvals. And we're very, very proud of that. We also facilitate scientific meetings and workshops where we bring the scientific community together. But I think most importantly, what we do that relates to all of you is we involve patients in our grant review process. So every year we recruit patients to help review our grants. And it's a wonderful thing to involve patients in their perspective in some of the research that we fund. So that is an opportunity if you all are interested in getting involved with that. And I wanted to highlight just how important melanoma research is. We call this our multiplier effect, but melanoma research has really led the way in so many other discoveries for other cancers. So immunotherapy and targeted therapy alone have led to treatment options in all of these other cancers and diseases. And it's really amazing. And that's why I always say investment in melanoma research is so critical, because it's not just helping melanoma patients, it's helping so many more people. And I think this is just incredibly impactful. So education, that is why you are all here today. It's the second part of our mission. We have a host of educational materials and events and opportunities. So I would encourage everyone to visit our website, melanoma.org. All of our materials are free. We ship them all over the country. We send them to doctors' offices, community events, schools. We have information for kids to prevent pediatric melanoma, all the way up through our stage 4 treatment materials. So this is just kind of an overview of our education. And again, all of these are available online, free of charge. You can order them, we'll ship them right to you. We also have videos. Again, these are short videos, 6 to 8 minutes animation at a 6th grade reading level to explain really complicated melanoma treatments. So again, if you're interested, we have those on our website, as well as our monthly Ask the Experts series, which are online webinars. And you can see all of our videos, they're all on YouTube. So if you ever are looking for a particular topic, you want to know more about a specific treatment, I would encourage you to visit our YouTube page where you can put that in there and find a specific video on the topic. We also have a patient forum. It's an online patient forum. It's a peer-to-peer resource. So again, if you want to reach out to others who may be going through something similar for you, you have a question, you feel more comfortable asking it in a forum versus asking maybe even your doctor, this is a great resource. So our advocacy program, just to touch on the third pillar of our mission very briefly, we have both state and federal advocacy efforts. Just this past March, we brought over 70 advocates to Washington, D.C. to meet with our lawmakers to talk about issues that are impacting melanoma patients in the wider community. We host that event every single March. So if you are interested, we had several advocates from Florida, but we would always welcome more people to come and talk to lawmakers, especially right now with some of the cuts that are being proposed to melanoma prevention and melanoma research. It's very important we have the patients talking to their lawmakers about why it's so important to continue investing in melanoma research. We also have state advocacy initiatives and mobilizations, and we also host webinars on some of the issues as well. You probably saw when you walked in our hashtag Get Naked campaign. This is our annual awareness campaign encouraging everyone to check their skin, to check their loved one's skin, and to see a board-certified dermatologist once a year for a full-body skin screening. So this is our big campaign, again, every May. We also have other campaigns. We have a pediatric melanoma campaign. You can see our cute little Spot the Dog down there. We have a campaign for our ocular melanoma program, as well as our mucosal. And again, all this information is in your packet, but we have a Miles for Melanoma annual 5K walk-run series. We host 17 events all over the country. And here are some of our upcoming dates if you have friends or family living in those areas. And lastly, I think a few of you might have picked this up on your way in, but there's a Cancer Today magazine, the newest issue. We have a wonderful ad in there featuring our education program if you want to check that out. And again, there are many ways to get involved with the organization and support our work and meet other advocates. And again, I would just encourage you all to visit our website. But if you're here locally in Jacksonville, come out this fall in October for our Get Naked Jax event. That's a great way to meet other people in the community. So with that, I just want to thank you all so much for being here. Again, we're so excited to have our first annual event. Please share your experiences with us today through the survey, through social media, if you choose to do so. But again, we're really grateful. And I just wanted to also introduce, she wasn't here when I started my talk, but Miriam Kadosh, who's our Director of Education and Patient Engagement. Miriam is a phenomenal resource for our patients. So I would encourage you all to meet Miriam, introduce yourself, and if you need anything at any point during your own melanoma journey, to reach out to Miriam as well. So thank you. Yeah, sure. Any questions? There's one right there. There's our microphone. We're just going to grab you a microphone since we have our virtual attendees.
Test,
Yeah,
test.
did you have a question?
I wonder if your slides are available because the one you showed with all the different cancers that melanoma research has affected. I think that's very powerful if you wanted to talk to a lawmaker to say, I'm not just talking about melanoma, I'm talking about all these other.
Yeah, her question, I'll repeat the question. No, it's a great question. She was asking if my slides will be available because the multiplier graphic that I showed about how melanoma research has impacted so many other diseases. I believe yes. And it's also on our website. But you're right. It's a very impactful talking point when you're talking to lawmakers about why funding research is so critical.
And our website is melanoma.org. Super easy.
Mm-hmm. Great. Well, I will be here all day, so feel free to come up to me at the break or ask me questions at all throughout the day. So thank you.
Awesome. Thank you. Is this your book?
Thank you so much.
All right. All right. Next, it's my privilege to introduce Dr. Tolaymat. Dr. Tolaymat and I are colleagues. We share patients all the time. She and Dr. Hall run our TVEC program, our interlesional therapy for melanoma program. She's an assistant professor in dermatology. She serves as a residency program assistant, residency program director. Her clinical and research interests include transplant dermatology and melanoma. And she'll be talking this morning. She'll be giving us an overview of melanoma.
Thank you, everyone. So happy to be here. So we'll dive into melanoma. So first, we'll kind of just level the playing field and talk about melanoma. What exactly is it? What does that mean? And so melanoma is a cancer of melanocytes, and melanocytes are the pigment-producing cells within our skin. So why is cancer an issue? Well, most of the time our body works in harmony. Every cell respects its neighbor and it has a function, but cancer causes a mutation within a cell, and so it no longer starts to function properly, and it also stops respecting its neighbor's boundaries. And so it allows it to multiply and also spread to other areas of the body, which can affect our longevity. The other thing a cancer can do, and melanoma is particularly good at this, is evading the immune system. And normally our immune system is very good at fighting infections or controlling things that are abnormal within the body, like a cancer cell. And some of our newer therapies in melanoma treatment have been designed to support the immune system in recognizing and fighting off melanoma cells. So as I mentioned, melanoma is a cancer of pigment-producing cells within the skin. So this is a drawing of a melanocyte. And then when we look at it under pathology, this is what a melanocyte would look like over here. So the function of the melanocyte is that it makes a pigment called melanin. And that pigment melanin is transferred to the major cell within our skin called a keratinocyte. So this is the keratinocyte here, and this is the nucleus of the keratinocyte. And the nucleus of the keratinocyte holds the DNA. Ultraviolet light can come into the skin, cause damage to the DNA, which can lead to cancer. So the purpose of the melanin is to act somewhat like a sunscreen to our keratinocytes. So the melanin is typically positioned in the keratinocyte above the nucleus to prevent the damage to the DNA. So you can tell that the melanocyte has a very important protective function within our skin. And then depending on the type of melanin that your body makes and the amount of melanin, that will determine our skin color. So as we talked before, unfortunately, melanoma incidence is only growing in the United States. Approximately 1 in 5 Americans will be diagnosed with melanoma. It is estimated that there will be more than 200,000 new cases of melanoma this year. This is an increase of about 6% from previous. And it's expected to unfortunately take about 8,000 American lives. If this rate continues at its current pace, it is estimated that melanoma will become the most common cancer in males and the second most common cancer in females. So I think it's really important that we understand melanoma and support the good actions of the Melanoma Research Foundation. So the 5-year survival of melanoma, and so when we look at patients who are diagnosed with melanoma, we often look at it, how they'll do in 5 years. And in the United States, they have a good 5-year survival rate of 94%. So that's a diagnosis of all comers. When you have an early melanoma, one that's detected early and treated early, the 5-year survival is excellent, 99%. However, it can be really challenging to detect melanoma early, and sometimes it progresses before it's detected at that level. And so if the melanoma has the opportunity to reach to lymph nodes, then the survival rate falls to 75%. And then if it goes to other organs like the brain or the lungs or the bone, then the survival rate drops even more to about 35%. So who gets melanoma? Well, it's actually any of us could develop melanoma, and it's regardless of our skin type. So any skin type can be susceptible to melanoma, and it can occur anywhere on our body, from the scalp to the bottom of our feet. But there are some individuals who may be at increased risk compared to someone else. So that would be individuals with light complexions, light eyes, blonde or red hair, history of blistering sunburns, especially in their childhood, heavy freckling, poor tanning. If someone has multiple moles, so if you have 50 or more moles, that's another risk factor to develop melanoma. There are some patients who have birthmarks that are quite large, and those may be at increased risk to develop melanoma within those birthmarks. Those patients who have a lot of atypical moles, meaning they look abnormal, or when you have them sampled under the microscope, your pathology comes back as that being atypical. And then finally, if you have a family history of melanoma, that increases your risk. So that leads us to how the diagnosis of melanoma is most often made. So a melanoma can appear on the skin suddenly, and that's how most of the time it happens, about 70% of the time. About 30% of the time it can come from a pre-existing mole, and it's most frequently on the torso, the lower legs, and the head and neck area, though as I mentioned before, it really can happen on any area of the skin. So because melanoma comes from melanocytes, and melanocytes are the pigment-producing cells, it's not surprising that what the cancer looks like on the skin is a dark area, though there are some subsets of melanoma that don't have any pigment, and so they tend to be pink in color. And you can imagine that's quite challenging to diagnose. Now, you can see that this melanoma is quite obvious, but as I'll show, sometimes early melanomas are not quite as obvious to diagnose just with the naked eye. So when you see the dermatologist for your skin check, there are some clues that we look for with your brown spots, your moles, to help to lead us to whether something is suspicious. And those criteria are called the A, B, C, D, E's of melanoma. So A stands for asymmetry. So that's where one half of the brown spot does not match the other. B for an irregular border. So it's not a nice round brown spot. You can tell it's got notches, blurred borders, it's irregular. C for multiple colors. So instead of being a nice tan brown color, you can see this spot has multiple colors. So that could be white, pink, tan, dark brown, black, or gray. D, I have two things I like for D. One is the diameter greater than a eraser tip of a pencil, but the other is D for different. I call it the ugly duckling sign. So you have lots of moles, but that one that looks different, that could be a problem. And then E for evolving over time. So this, we usually need help from our patients, and they usually give us the history that, you know, this seems to be growing, this seems to be bleeding, it's changing, and that can be an important piece of information. So this is a very typical melanoma. I think we'd all look at this and be concerned about it, but what you can see is that it is asymmetrical, meaning this one half does not match the other. It has an irregular border, definitely has multiple colors. And you can tell by this, it's bigger than an eraser tip of a pencil. And I bet this patient does not have anything similar on their body compared to this. This is another picture of a melanoma. So this is on the side of the face. And you can tell again that it's asymmetrical. This half doesn't match this. It has very irregular fuzzy borders, multiple colors. It's large. And my suspicion here is it's been growing slowly over time. This I love because this is my favorite of an ugly duckling sign. This patient has pristine skin except for that one brown spot. And you can tell it's irregular, it's asymmetric, and has multiple colors. This is a more advanced melanoma, and the reason I say that is you can tell it's actually a bump off the skin. The other thing that you can tell about this is that the surface of it has been eroded. It's like a sore, and we call that ulceration. So sometimes we can see ulceration with the naked eye, but most of the time that's actually something that the pathologist is able to tell us under the microscope. And that piece of information is really important as we talk about staging. So as I mentioned, not all melanomas are as obvious as what I had presented. And I think that's the challenge to dermatologists and our patients in terms of early detection. So there is a tool that we use in dermatology called a dermatoscope. And so this is an optic with transilluminating light. It helps to allow us to see into the skin beyond the reflection of the light off the surface of the skin. We learn certain patterns in dermatology that help to tell us whether this is something that we need to be alarmed about or whether it is something benign. And I often explain this as, kind of the middle point between what I can see with my naked eye and what the pathologist can tell me under the microscope. So this is a melanoma. This is an early melanoma in situ, and we'll discuss that in a moment. But you can tell this is not quite as obvious. That may not pick up your attention very much. But yet when I, as a dermatologist, look at it with my dermatoscope, I see some features here that to me are concerning for melanoma. I see atypical pigment network, milky red areas, and blue-gray dots. And that isn't anything for, our patients to necessarily focus on, but just know that the dermatoscope can help us really look at some of those pigmented lesions that maybe aren't as obvious melanoma so that we can make that diagnosis for our patients earlier. So, we have a full skin check and there's a spot that's of concern to your dermatologist. And the next thing we're going to do is recommend a biopsy. And the reason for that is that we do need to take that tissue and send it to the pathologist. And so there can be different ways to take that sample. One of the more common ways is called a shave biopsy. So this technique has to be refined by your dermatologist because we typically take a margin around the brown spot as well as really scoop way deep underneath to make sure that we don't transect the melanoma. And we'll talk about that in a moment. A punch biopsy is usually better for really small spots that we're suspicious of a melanoma. It comes in the size between 2 millimeters and 10 millimeters, so we certainly can't get every melanoma with this. But it does allow us to get full thickness. And the other nice thing about this technique is we can put stitches in so the area heals more quickly. And then finally, when we're very suspicious, we may recommend what's called an excisional biopsy, where we take the full thickness of the skin using a scalpel blade. We cut that area out as an ellipse shape. We stop the bleeding, we put in a layer of deep stitches, a layer of top stitches, and then that whole specimen is taken to the dermatopathologist for evaluation. So then we get to the pathology report. We've sent the specimen in, and if you receive care at an institution like Mayo Clinic, those pathology reports are available to patients as soon as the pathologist has had the opportunity to review it. And so you will look at your patient portal and see this. So two very important pieces of information from the pathology report. This is just a mock pathology report. But the two most important pieces of information after the diagnosis of melanoma, one is called the Breslow thickness, which we're going to talk about, and the other one is whether there was ulceration identified or not. So the Breslow depth is the depth of the melanoma that is measured by the pathologist under the microscope. So they start at the very top layer and they take the measurement where it goes to the deepest level. And melanoma in situ is equivalent to a Breslow depth of 0. So what that means is it's completely contained within the top layer of skin called the epidermis. Once it goes beyond the epidermis, then you will actually get a number from the pathologist. And you can see here, for example, this is a thin melanoma that's gone beyond the epidermis. This is getting a little thicker here. And then finally, this is a very thick melanoma, which has invaded through the second layer of skin and encroaching on the fat below. So then this what's happens. I've been diagnosed with the melanoma. Now what? So the first part that we work on is staging. And what staging is helpful for is it describes the extent or the severity of the person's cancer. And we have to know that to know how we are going to make a treatment plan and then how we're going to follow a patient moving forward. So as I mentioned, what's important, the thickness of the tumor or the Breslow depth is very important, and whether the tumor is ulcerated or not. So those two pieces of information, hopefully we gather from our pathology report. Then some other pieces of information, and this depends on, your Breslow depth and whether you have ulceration, whether we need to move to these next two steps. But we have to determine whether the melanoma has spread into the lymph nodes. And a lot of times this is where I partner with Dr. Jacob to help to answer this question. Sometimes we know by palpating lymph nodes if we feel something enlarged. Sometimes we'll find it on imaging, like a CT scan or a PET CT scan. And then finally, we do look for melanoma when it's not yet visible on imaging and not yet affecting the lymph node to where we can feel it. And that is called sentinel lymph node biopsy. That's a technique which Dr. Jacob will talk to you more about. And then also finally, unfortunately, melanoma can spread beyond those areas, and that's where imaging can help us. And Dr. Dronka will discuss more of that upcoming. So staging for melanoma. Melanoma in situ, an early stage 1 melanoma is where you're going to probably be managed almost exclusively by the dermatologist because these melanomas are cured with surgical treatment. And then as we start to get to the thicker of the thin melanomas, then that's when we would partner with Dr. Jacob, who's a surgical oncologist, as well as our medical oncologist. So stage 3 melanomas where it's spread to the lymph nodes, and then stage 4 is where it's spread to other organs. And there's a lot of our team members who are going to be dedicated to your care as a melanoma patient. And so I also already mentioned my role as a dermatologist, the role of Dr. Jacob as a surgical oncologist, Dr. Dronka as a medical oncologist, but we have so many other members of our team who are going to take good care of our patients. And so I'll dive in a little bit to melanoma treatment, but I'm really going to stay in the area, as I mentioned, with those patients who have early stage melanoma, which we treat within the realm of dermatology. So that's typically going to be your melanoma in situ and your very thin melanomas. So that's Breslow depth less than 8 millimeters who don't have any other high risk features, and one that we would not necessarily need to send for sentinel lymph node biopsy. So the most common surgery that we perform is what's called a wide local excision. And so this is done under local anesthesia. So this would be done in a procedure room in the outpatient practice. We anesthetize the area, and then we remove a large margin of skin and also the underlying fat. It's usually closed in a straight line. And if I do this in dermatology, I would not do sentinel lymph node, but if Dr. Jacob is going to be taking care of a patient, he may or may not be doing this procedure under general anesthesia with sentinel lymph node biopsy. Regardless, this tissue is sent to the pathologist, and they help us to ensure that we did get clear margins. The other technique, surgical technique that we may use is Mohs micrographic surgery. And this is usually used in areas where we can't take a generous margin. So you can imagine on the face, the tops of the hands, the feet, the genital skin, there's not a whole lot of real estate, and we have to be very careful about the amount of tissue that we take. And so when you see the Mohs micrographic surgeon, you would also see them in an outpatient space, and they use local anesthesia. And what they do is they remove the visible cancer along with a more narrow margin around and under this cancer. And then it goes for immediate analysis to the lab. The patient will have a temporary bandage on while we wait for those results. For melanoma, it is recommended that some special stains are performed as we're processing the tissue. And unfortunately, not every facility has those capabilities. We're very fortunate at Mayo Clinic that we can offer those specialized needs for our patients. So the surgeon will take another layer of tissue if it's found that we have not cleared the melanoma. So we keep repeating that cycle until the melanoma has cleared. And then the Mohs surgeon or the plastic surgeon would discuss how we would then repair that wound for the best cosmetic outcome. Now, as you can imagine, follow-up is very important after you've had your melanoma treatment or undergoing treatment. And so in general, you will have a skin check with your dermatologist every 3 to 6 months, just depending on your own personal history and the severity of the melanoma. We usually recommend eye exams once a year because a small portion of melanoma can occur within the eye, and that is one place as a dermatologist that I can't look. And then, of course, if you're following with medical oncology, they may recommend imaging be done for screening, and so you'd have that done as their recommendations. Other than your skin checks, what we focus on at your follow-up visits is sun protection, making sure you're doing your monthly skin exams. And then I always tell patients it's very important to have your first-degree relatives screened as well, because once you're diagnosed with a melanoma, their risk increases as well. So we talked about the ABCDEs of melanoma, but you're going to use these same concepts as you're doing your self-skin checks at home. So just as a reminder, A for asymmetry, B for irregular border, C for many colors, D for eraser tip greater than a pencil tip of a eraser tip of a pencil, or the ugly duckling sign, and then E for evolving or changing over time. Here we go. And then the American Academy of Dermatology, as well as other respected organizations, really encourage patients to perform monthly self-skin checks. This gives a diagram about how you can use mirrors and positioning to help you look at all areas. I will say that there's good data to suggest and support that you have a family member or a partner help to check you as well, because that increases our ability to detect melanoma. Finally, I will say that, there is an emotional impact with the diagnosis of melanoma and also undergoing treatments. And so I do want to recognize that this can be quite overwhelming for patients and their families. There's a lot of emotions that can be experienced by patients, all are which of normal, but I've seen them all, uncertainty, anxiety, fear, anger, sadness. What I do want to emphasize is that getting education really can help patients and their family members feel like they can regain some sense of control. And so I do recommend that, you work on good education for yourself and your family. There's many great organizations like the Melanoma Research Foundation that you can access their patient materials, Mayo Clinic, but with access easily available on social media. Just remember, not everywhere is going to have reputable information. So making sure that you get your information from the right sources. And then also just feeling, comfortable asking your healthcare providers about any questions that you have. We are here for you, and we care for you in your best interest. So, we look forward to having all your questions and making sure that you feel comfortable with the information that we're presenting and your treatment options. So thank you, everyone.
Time for questions, and also, is my mic on? Yes, you do. We'll have time for questions, and also the folks online, they can type in questions on the Zoom. We'll pass around the mics to people online.
Is it on? Oh, good. Thank you very much. Dr. Tolaymat, nice to see you again under different circumstances. So I've been treated by you and by others on 3 different occasions for excising a melanoma. The one you did was quite deep. What puzzles me about this is the randomness of the disease. We tend to think of cancer as an organ or a part of a body that's isolated, but this doesn't seem to work like that. Could you shed any light on this?
Right. No, thank you. That's a great question. And I think that's where we've struggled with melanoma for so many years. And probably one of the reasons why just until recently we didn't have so many great treatments for melanoma. What I will say is the skin is the largest organ in the body. It has different cell types within it. And so melanocytes tend to be one of them, but they're scattered everywhere. And so whether it's ultraviolet light that causes the damage to the melanocyte that eventually triggers that to turn into cancer, or whether, it's a genetic predisposition coupled with that, it makes it really hard to predict where and when someone will develop melanoma.
Hello. Is there a role for artificial intelligence in helping you diagnose a lesion?
So yes, and I think that will be coming. That is, I think, the wave of the future. And, we're trying to work on that at Mayo Clinic as well, help us with early detection using things like artificial intelligence coupled with imaging of patients.
Thank you so much, Dr. Tolaymat. My professional career has been in psychology, and I'm just wondering if there's been any research on the symptomatic melanoma and psychological stress or trauma or whatever, and in terms of the development of abnormal cells, but also in the who recovers and who doesn't as successfully and as quickly.
Yeah, so I think there's a very robust literature in general with cancer in terms of, coping mechanisms. And you're right in terms of, I think what you're asking is, does the patient's mindset affect, their recovery? And I would say there is good literature to support that. So one of the team members, unfortunately, that I failed to show on my slide is, all our wonderful group support that we offer at Mayo Clinic, as well as those who, work to support the patients emotionally and give those resources, because I think that that is a really important part of their recovery.
Thank you. Also, the development of melanoma as well as other cancers. Is there any any research that would support the body-mind connection? I'll say that more clearly.
So you mean before the melanoma has developed? I don't know that I'm as familiar with that research.
An online question. What is the difference about the stains that are used at Mayo?
Oh, so typically when we use the stains on frozen tissue, it's just the regular H&E stains. So the ones that are used at Mayo Clinic are MART1, which are specifically pick up the melanocytes within the specimen. But that can be a very tricky stain. And so you have to have the technology and the technicians who are skilled in making those slides come out so the Mohs surgeon can read it. And then not all Mohs surgeons have the skill set to read those slides.
Hi, I was recently diagnosed and treated for a very superficial melanoma on my face. And so my two questions. One is, once one has had any level of melanoma, does that change the recommendation for screening? Is it yearly? Is it twice yearly? And then second question, I was told that all of my first degree relatives, including my children, should get screenings yearly. And if that's the case?
Yep. So we do recommend that all your first degree relatives, so parents, siblings, children, be screened once a year. If you see the pediatric dermatologist, they may, depending on digging into the family history a bit more, spread that out for younger children. But typically, we like to see patients yearly. What I will say about the melanoma in terms of our recommendations for how frequently you come depends on the depth of the melanoma. So if you had a melanoma in situ, for example, we probably aren't going to be seeing you every 3 months. And then it also depends on the other skin cancers you have, because patients with melanoma are at increased risk for the other skin cancers, basal and squamous cell carcinoma. So depending on your history with those skin cancers, we may be seeing you more or less frequently. Sure. All right. Thank you, everybody.
I'll get your question. I'll get your question after the next speaker. Yeah. All right. So, in talking about the question about melanomas popping up in different places and unpredictable, I have a colleague of mine who's a surgeon in Peru, and the disease he sees is significantly different than the disease we see here in the U.S. Patients really advanced, late stage, like needing amputations of hands and feet and stuff. And it's very interesting because there's some theory, Bob Marley died of melanoma. I don't know if you know that, on his toenail, and that's an acromelanoma. We see that in people of color on the palms and soles of their feet more often, and not the sun-exposed area. But there's a new theory going around that Peruvians, the indigenous Peruvians, walk barefoot, and it's very rough surface. And they think actually the repeated lifetime of trauma actually may be one of the instigators to form melanoma, as opposed to the sunlight that we think of for most of us who are not people of color. So just a little interesting thing there that I learned recently.